So let's do a little audience participation. We're talking about payment reform and provider reform. So how many in the audience, and I'll ask you to stand, have a primary care provider? And what that means is you've got an internist, a family physician who is providing, or an advanced practice clinician, who is providing continuity of care for you, and you've seen them a few times and they know who you are, and you think you know who they are. So with that definition of primary care physicians, please stand up if you feel like you have one. So I do this a lot, and this is a very big representation. I would say this is almost 75% have primary care providers. We usually see maybe 50%, 60% have primary care providers. And for, no, stay up. We're not done. No. I'll make you sit down in a second, but for those people that are sitting and are feeling a little uncomfortable and a little uneasy, they're indicators of health. There are two main drivers of indicators of health. One is that you have a stable relationship, so we won't go there today. But the other is that you have a primary care provider, and if you are still seating, we have the booth out front, and you can go and we'll fix you up with a primary care provider and get you on your way. If you're standing and you have a primary care provider, how many of you can interact with that primary care provider on this device or an iPad or any other kind of handheld device and get your prescriptions, your appointments, your lab results, and have an e-message securely with that provider? If you can do that, stay standing. If you can't, please sit down. So that's very good. I mean, we now are probably at 40% of the audience still standing, which is huge compared to where we were last year. So if you're getting nauseated by my conversation and you start feeling sick and you say, I need to see my doctor this afternoon, how many of you that are still standing feel like you can get in to be seen this afternoon? If you can, stay up. If not, please sit down. That question last year in this meeting sat most of the audience down, so we've got some improvement in access. So the people that are still standing, how many of you have gotten a pre-call that says, Mr. Smith or Mr. Jones or Mrs. Jones, we haven't seen you in a while, and we think that you need to get such and such and such and such done, and so we're setting up an appointment for you. If you've had that occurrence, please stay standing. If not, please sit down. Most of these guys I recognize, and they come to our providers, but I think if you're still standing, you are probably in a patient-centered medical home or in a practice that's aspiring to that. So thank you, and you may all sit down. So we're on a journey, and I first have to talk about the Sisters of Bon Secours. Bon Secours means good help. Then the Sisters of Bon Secours in the mid-1800s in Paris were wonderfully innovative nuns, and where they went to was trying to take care of patients out of the hospital in their homes, and really did a unique job because they found that in the home it's safer, there was less infections, and the patients improved better through that kind of nursing care. We try to do that in the medical group, and it's really nice to have the sisters on your side, and they love what we're doing, taking care of on the ambulatory side of our patients. So why is the system not working? And very quickly, physicians aren't happy. Primary care providers aren't a happy lot right now, and it's sad. Workforce, I think Secretary Hazel talked about the physician workforce challenge. Patients aren't happy. Patients don't have access. Patients don't have insurance, and so they're not happy. Employers aren't happy. It's too expensive. We're not getting what we're paying for. We're not doing, and then we're in this fee-for-service world that John talked about, where all the incentives are really broken to what we're trying to establish and really accomplish. And so nothing really is, working well. And then along comes, healthcare reform, and this is going to hurt. And that was the cover of The Economist. I didn't make that up. And And so we're going to have challenges to change what we're doing, and we have a lot of incentives to change. But from my perspective, I think this is a very exciting time for us as delivery system folks to make the changes that now can drive the insurance companies to change. So it's a new world. We declared a couple of years ago, it's a new world. We've got to do something different to make the world different. So Bon Secours Medical Group took this on as our challenge. We're going to transform our care. We're going to fundamentally do something different to transform your lives and the lives of our patients and the communities that we serve. And we needed to do that because what we were doing before was not working. And unless we fundamentally change our activity, we weren't going to get anywhere. So this is our journey, and I won't go through it in super detail, but we started this about 3 years ago. So we first went on electronic medical record. We've grown strategically. We've re-engineered all of our practices, or we're still in the process of that, into patient-centered medical home, and I'll talk a little bit about that today. We established the patient portal, and 3 years ago, we had no patients interacting with us. Today, we have over 75,000 patients in Central Virginia and Newport News that are communicating with us on a daily basis on MyChart, which is our patient portal. We've introduced a new clinician into the mix, a nurse navigator. This is an ambulatory care manager, usually an RN, who we now have 42 going to 70 next year, who are very much involved in helping our care team manage your care and find the gaps in care and interface with folks, high-risk patient interactions, and really assisting the physician. And I was in a meeting with our nurse navigators not long ago, and they were all feeling like they were overwhelmed. But they were in providing care that wasn't being provided before. And so it was all this unmet need that they were working on. We use registries very actively and proactively, and what registries do is look for areas where we're not delivering the kind of care that we need. So one of the things that we talk about is we're more concerned about the patients we don't see than the patients we actually see, and we have to figure out how to do that. High tech, high touch, we're doing lots of different things. Medical group now has home care and hospice inside the medical group, and it connects the continuity of care and the transitions of care in a more real way. We synchronize what we're doing, but that whole journey was designed, intentionally designed, to change the payment model, the fundamental payment model. This is a fee-for-service state. And 2 years ago, we started taking a very clinically oriented group of providers with our managed care contractor folks to the payers and saying, look, we're on this journey. You need to help us by changing the fundamental payment structures that you have. And I'm here to report now, 2 years later, every one of our contracts, with a couple of exceptions, has an enhanced payment model for care management, enhanced pay for performance, and either shared savings or some other mechanism for us to enhance what we're doing over fee-for-service to align our incentives better. And then what we have next is healthcare without walls, which is going back to our roots with the Sisters of Bon Secours. Little bit, our medical group, we're now over 460 providers in over 100 locations across the state, and about 2/3 here in Richmond and 1/3 in Hampton Roads. Now this is a great diagram or a cartoon, and you can imagine the primary care provider is the patient, and that's how they feel. And the primary care patient is there, and it says, now open even wider, Mr. Stevens. Just out of curiosity, we're going to see if we can jam another tennis ball in your mouth. And that's how the primary care providers are feeling, overwhelmed, overstressed, and really not one more thing can be given to us for us to improve. So we're in medical home. Medical home moves the day-to-day activity away from an individual doctor and places it on a team base of care and smooths the workflow out in a very dramatic way. And this, I believe you're all getting these in a handout, but a couple of things. Today's care is really my patients or those who make an appointment and see me. Well, in a medical home, it's those patients who are I'm taking care of, whether I see them or not, and I'm concerned about the ones I don't see more often. Patients' chief complaints or reasons for the visit determines the care I give. When the medical home, it's a very systematic assessment of your needs, not just your today's complaint that we try to solve on the visit. Care varies by scheduled time and the memory or skill of the doctor. You believe that? Well, it's true. But what we're really looking for is standardized treatments that are evidence-based and out in very specific guidelines and a system. It's very proactive. It builds a new delivery model that we can build into an accountable care organization, and we've accomplished that. And then there's a philosophy of care that's different. It's team-based, not individual-based. And Dr. Hazel talked about, training. We were trained to be individuals, and that's a real challenge, and can't do it. So medical home in Virginia, not so strong, 32,000 across the U.S., 671 here in Virginia. So we have a long way to go to build medical homes across the system. And I'll skip through some of these things to get to our experiences. One payer, 1 year, 9,000 commercial lives. We've reduced their spend $1.2 million, 35% reduction in readmissions. Busy slide, but it's our employee activity where we attend to the low risk, the moderate risk, and the high risk employees and have specific programs for each of those categories. Last year, our budget raised our spend by 11%. Our actual spend went down 2%. So we were actually able to bend the curve down 2%. We have managed care contracts with each of our payer that have alternatives, but we're now participating in the Medicare Shared Savings Program, which is about 25,000 patients across Virginia with 33 quality metrics that we're meeting. Very exciting program and really changes and refocuses us.